The next presentation is another rapid-fire presentation, real-world experience with a human acellular vessel, a bioengineered implant for arterial repair that expands limb salvage options by Dr. Loria.
I'd like to thank the VESS committee and VESS for allowing us to present today. I'm Dr. Kersey. I'm one of the residents working with Dr. Loria and our team. And today I'll be discussing the real-world experience with the human acellular vessel known as HAV, which is a bioengineered implant for arterial repair that expands limb salvage options. We have no disclosures. In instances of vascular trauma and critical limb ischemia where autologous vein is unavailable, a durable infection-resistant conduit is imperative for successful vascular reconstruction and limb preservation. Prosthetic conduits are immediately available, but use can be limited in infected fields. The HAV, or human acellular vessel, is a bioengineered conduit with off-the-shelf availability and a proven resistance to infection. As depicted here, the HAV starts as a biodegradable mesh scaffold, which is seated with human vascular smooth muscle cells. The developing conduit is contained within bioreactors where it undergoes pulsatile cyclic distension for about 8 weeks. Following, this product is decellularized to remove any immunologic potential, leaving behind a tubular extracellular matrix which is used as the conduit. This is a case series that describes HAV implantation and early outcomes in patients with critical limb ischemia or vascular trauma who lacked alternative conduit options and who would have otherwise undergone amputation. The Food and Drug Administration Expanded Access Program was used to allow urgent HAV implantation through compassionate use indications. Patients included those with critical limb ischemia, including rest pain and tissue loss and severe vascular trauma. All patients lacked suitable alternative conduits due to the absence of autologous vein, instability precluding harvest, or current prosthetic graft infections. The bypasses range from axillary femoral to tibial and iliac reconstructions, and 6 of the reconstructions included composite HAV to HAV conduit or HAV to vein conduit. Following implantation, medical records were reviewed for early outcomes. 2 patients presented with rest pain and no available autologous vein and underwent femoral to tibial arterial bypasses. These bypasses remained patent for 20 and 9 months respectively. The following 2 patients presented with infected pre-existing prosthetic grafts requiring graft excision. One patient underwent axillary to profunda bypass while the other underwent femoral to tibial bypass, both using composite HAV. Due to complex underlying disease with the first patient ultimately elected withdrawal of care shortly after surgery, while the second patient remained patent at 6 months. Notably, during the autopsy of the third patient, the HAV was noted to be uninfected despite implantation in an infected wound, with evidence of epithelialization of the luminal surface of the HAV less than 2 weeks after implantation. 3 patients presented with tissue loss and underwent femoral to below knee popliteal and tibial targets, while 1 patient had early postoperative thrombosis due to significantly limited outflow. The remaining 2 bypasses were patent at 19 and 4 months. The final case is a patient who sustained severe penetrating pelvic trauma with injury to bilateral iliac arteries and veins. There was significant soft tissue loss. Emergent HAV implantation was used to repair these defects. Unfortunately, the patient ultimately required a hemicorpectomy for extensive soft tissue loss and invasive fungal infection. Notably, the HAV was not noted to be grossly infected at the time of that surgery. Shown here is the extensive surgery this patient underwent. On the left with shunts in place, and on the right, the artery and vein with HAV conduits in place. In conclusion, preliminary experience with the HAV has demonstrated reliability in the face of infected fields and severe arterial disease. This is an early series of 5 bypasses, averaging 11.4 months with a range up to 20 months of patency. Most notably, no HAV infections were identified despite placement in contaminated fields in the setting of trauma and pre-existing infections. The HAV may greatly expand opportunities for limb salvage and trauma and urgent vascular reconstruction in patients with no other options for conduit. Thank you, and I'll take any questions.
Thank you for that presentation. My question really has to do with the use of this in trauma. Are you suggesting to do this rather than put a temporary shunt in a person who is unstable?
No, I think shunting definitely still has a role to maintain patency and flow. I think this is just an option for folks who have potentially mangled extremities and someone who's potentially a blast victim or has a lot of tissue that needs washout and has potential for infection.
Gotcha. Dr. Humphreys?
Misty Humphreys from UC Davis. I really enjoyed this talk.
Thank you.
Because in a lot of patients we have a population of very advanced chronic limb-threatening ischemia where there's not a lot of conduit sometimes. So I have two questions about this device.
Okay.
One, does it, it's a acellular matrix, but does it have any ability to develop endothelialization along the matrix itself? Or do you know if that happens? And two, have you seen any breakdown of the graft over time? Some of the other products that we've used like this, after 3 or 4 months or even 5 to 6 months, you start to see that it dissolves or it becomes aneurysmal.
Yeah, thank you for the questions. To answer your first question, in our case series, we did see early vascular ingrowth of smooth muscle cells and endothelialization. So there are further studies going on to answer that question more. Unfortunately, I don't have the experience with this to answer the second question appropriately. I believe one of the hemocyte reps is here who can probably better answer that.
Yeah, really nice presentation, and in the military, I've been looking for these kinds of things forever, right?
Absolutely.
Find something off the shelf. Usually in trauma patients, you can find some vein to fix things, but it may be the situation, and I think you have shunting options, you have other options, but it gives you a potential another use. One of the questions that always comes up when you use these things: what's your anticoagulation plan on these patients? If you're doing this for CLTI, antiplatelet anticoagulation plan that keeps these things patent.
That's a great question. Is variable, and I think further studies are going to help delineate exactly what that anticoagulation plan needs to be.
Great presentation. Quick question. So I've used this several times for the AV fistula study, and the graft itself is very thin, and so clamping it sometimes leaves the marks of the clamp, and you can almost see through it, kind of disconcerting. Do you have any techniques for how you avoid that? Do you just not clamp it, or use very soft jaw clamps, or what do you do?
That's a great point. Unfortunately, I personally have never used the device. I haven't implanted it myself, but I think Dr. Proper.
I put a few of these in. I don't clamp it. I always just clamp the artery. And the other question I think that Missy asked, we don't really know if it degenerates with aneurysmal time. Like these grafts have been in, the longest is like just under 20 months. And so that's kind of a long-term concern. There's some longer-term data from Poland. The patency data wasn't that good, in all honesty, but there wasn't a lot of degeneration seen that was published anyway in that series. So we don't think it degenerates, but we don't really know. And then in clamping, I just try not to clamp it. I just clamp the artery.
Chuck Fox from Baltimore. I feel compelled to just compliment you for your presentation and make a few comments, because I was the site PI in Denver for Humacyte, and I use it for fistulas, and I use it for trauma, and I put in about 30 of them. And I had very good response with them, and they didn't get infected. So that was the first thing that really impressed me, because that's the reason why we use it over saphenous vein, is when the saphenous vein isn't available and you want to put something in that resists infection. And I did have one clot on me because I clamped the graft, so I called Jeff Lawson, and he told me that you really shouldn't clamp the graft at all. So it was a subclavian artery injury, and I just, from now on, just clamp the proximal inflow native artery. But I was very impressed with the graft, both in popliteal and use for subclavian.
Thank you, sir.
Yeah, and my name is Mauricio Verdugo. I'm the head of medical affairs for Humacyte. And to answer the question about the degradation, we're currently very close to publishing a paper that talks about the long-term outcomes of the use of the HAV right now in AV access, but that will be able to answer the question about the degradation. What we have seen is that over time is that the HAV will remodel with the host cells, and it will look like a living blood vessel. So stay tuned for that publication, because it's coming maybe over the next couple of weeks.
Thank you very much.
Thank you.